Perfect. All right. Well, I think we should be good. Welcome, everybody. This is an interactive forum where we're going to do a panel discussion on how we can optimize care for patients who are exposed to xylazine and fentanyl, including the complications of wounds, withdrawal, management, laboratory confirmation, which we have a little bit of data, and then overdose management. So I'm just going to kick us off. Whoever's chatting, if you could just mute yourself, that would be great. I'm just going to kick us off. I'm not going to do the usual slides of pharmacology, toxicology. I think everybody has a pretty good handle on the sort of comparability of this drug to clonidine, an antihypertensive medication and a medication used for opioid withdrawal. So the goals for our discussion today are sort of to respond to the emerging threat.
It's about like xylazine. Let's see. Emerging threat to the xylazine crisis.
Let's see. Can somebody figure out who that is and mute them?
Hey, Katie Volosky, I think, yeah, there you go. Thanks.
Thanks. So the goals for our discussion today are to update everyone on some of our emerging practices for xylazine-fentanyl withdrawal management, and some new guidance that we've just posted on our website, which hopefully will be able to be a source for other health systems to share from. And then we really want to build collaboration for wound pathways, both within our health system and to many different outpatient low barrier centers where wound care is occurring, and then to really think collectively about how we can improve care for these patients and their experiences in the hospitals of Philadelphia. And then describing a little bit about what we know so far about laboratory confirmation, and then the continued role, and I think highlighting the importance still that Narcan is our best strategy for patients who experience overdose. And then maybe if we have a little bit of time, we'll talk about how we can study this. So I have one slide, and I'm sure people have seen this. The xylazine prevalence is highest in the East. It is being detected across the country, but really at no time is any place in the country experiencing what we are seeing. If I go back to data that I have from the medical examiner from 2012, there was probably 10% or so of medical examiner deaths were also detecting xylazine. But what's different about Philadelphia, and I'd say this region, Baltimore, and a little bit of the Northeast, is that the amount of xylazine in our drug supply per bag has gone up dramatically, and the amount of samples, in which xylazine is detected has also gone up. So, people quote 91, 95% of drug samples purchased on the streets in Philadelphia contain xylazine. So it's really not a little bit of xylazine, it's that there's a lot of xylazine that are getting people exposed in this area. So despite the fact that it might have some national exposures across the country, it's really something that we are seeing much more so, and something that I think puts us in a unique situation of being able to spread our learnings to places around the country. So when we first heard, we've heard about xylazine here for probably 3 or 4 years more commonly from patients, but I just wanted to turn it over to Tony to talk a little bit about some of the studies that we have done listening to people on social media.
Hi, I'm Tony. For people that don't know me, I'm one of the senior residents in the HUP ED and soon to be medical toxicology fellowship at Rutgers. So I'll be working at the Poison Center across the river in a few months. And so we've been using social media to learn about xylazine and people's exposure to novel psychoactives. There's someone maybe needs to mute themselves. So from this study, we looked at posts on Reddit describing people's experiences with xylazine. Reddit has a lot of advantages since it's primarily anonymous posting, so people are pretty open about their experiences. And using natural language processing, we were able to sort through a large number of posts to find which ones actually mentioned xylazine. They're a pretty small number, 76 total. And we found that those people were posting about xylazine all the way back in 2018, before that was probably on many of our minds. You can see some of the discussions that people were talking about xylazine. These were primarily in subreddits for people who use opioids. And in, some of these people are talking about it as a sleep aid. They're talking about like sort of a different sort of like sedation that they get from xylazine compared to opioids, some autonomic symptoms, and then also just sort of discussing about, is there, nature, their heroin or their dope, is it actually opioids or does it have xylazine in it? And if there's a huge open area market. Not included in these quotes are a number that mentioned specifically they were getting it in Philadelphia. And I think, this sort of is a way to look at what experiences people are having that maybe they're not necessarily coming to the hospital for. Next slide. So we also put out surveys on Reddit to have people on that social media site sort of describe their own experiences with xylazine. And most of these surveys were completed sort of in the first half of 2022. So probably even in the past year since we put out the survey, I'm sure some of this has changed a little bit. But, we were asking people, do they intentionally seek out xylazine? For the most part, people responded no. You can also see how they use xylazine. There's a mix of primarily actually intranasal is the most common way people reported, and then injection, and then the smoking or oral was like very, very tiny, which I think, shows some important things. And I think probably the role that xylazine test strips or drug checking can have if most people are not seeking this out. And then we also wanted to see what adverse effects people were experiencing from xylazine. I'd say a slight majority of people said they had experienced withdrawal from xylazine before. You can see some of the withdrawal symptoms they were having, a lot of psychological symptoms like anxiety, depressed mood, but also like things like body aches. And probably what's clear to everyone here is that overlaps significantly with what opioid withdrawal looks like. And so I imagine there's some, at least from a clinician standpoint, confusing of the two withdrawal syndromes. People are also reporting prolonged sedation and increased like skin wounds and skin infections. And a lot of people were saying that xylazine was making their withdrawal worse. And so I think, this is all sort of on the internet, like people's experiencing, and not necessarily the exact same patients or people that we're seeing in our emergency departments in our hospital. But I think this, raises some questions about and sort of informs some of what we do in the hospital. I'll turn it over to Ashish, I believe, is next to talk about what we're seeing in terms of xylazine withdrawal in the hospital.
Awesome. Thanks, Tony. Hey, everyone. My name is Ashish Takrar. I'm an internist, addiction medicine physician. I'm finishing up fellowship in the National Clinician Scholars Program and excited to be joining faculty at Penn. I'm going to talk a little bit about what we're seeing in the hospital. I think there's probably a range of folks on this call with different expertise and experience, but I think everyone who has looked into xylazine could probably agree that we just don't know very much. There's a lot of theorizing and a lot of questions, but I think one of the benefits we have right now in the Penn system is that we do have a GCMS urine test to test for xylazine. And from March 2022 until February 2023, we looked at all the tests that were sent. And so one of the questions we wanted to ask was, what are patients telling us that they're reporting if they have been exposed to xylazine? So we looked at the 73 cases in the Penn hospitals where there was confirmed xylazine exposure. And we looked to see, this was some of the camp folks did a really detailed chart review to see what were patients actually saying they were feeling, what was actually written in the chart in terms of what was documented about their subjective reports. And what we saw a lot of variability. Some patients were really vocal about what they were feeling, and that was documented in the chart by nurses, other clinicians. In others, there really wasn't that much that was actually mentioned in the chart. Doesn't mean that they weren't experiencing that, it just wasn't in the chart. But what we did see were examples of anxiety and restlessness. These are some illustrative quotes taken directly from the chart. Patient increasingly agitated and restless. Patient tearful and anxious. Mood is anxious. Affect tearful. Behavior is agitated. Patient requesting PRN anxiety medications. This is consistent with what Tony was reporting from the Reddit forums, and it's consistent with what I and others have heard from a lot of people who are using trank dope, is there does seem to be a shift that happened once trank entered into the drug supply, and there's a feeling of withdrawal, agitation, and restlessness that now accompanies the withdrawal syndrome that they were feeling before. We then went a little bit deeper in doing chart review for clinicians at Penn, all addiction experts, looked at all of these cases where patients had confirmed xylazine exposure. Our main question for this chart review is, could we find evidence of a withdrawal syndrome that was distinct from what we would expect from benzos and or opioids, right? What actual evidence can we find of a new withdrawal syndrome that we might attribute to xylazine? The first group, and this was the majority of cases, were a group of patients for whom there were no clear signs of something abnormal, no signs of any withdrawal syndrome. This was 71.3% of these patients. This group fell into two major buckets. One was mixed opioid and benzodiazepine withdrawal. There was a very high level of co-exposure to benzos for these patients. I believe it was about 43% of patients had benzos detected in their urine. And we know the urine tests for benzodiazepines aren't perfect, but there is a high mix and high burden of benzodiazepine withdrawal that was associated with that. It's really hard to tell what is xylazine withdrawal in a patient who's experiencing benzo and opioid withdrawal. So in our assessment, these were cases where patients did not have something new. The second group was the group of patients who received really aggressive withdrawal and pain management. We saw that a lot of these cases, whatever withdrawal syndrome they were experiencing really improved with opioids. And these patients often got high doses of interacting opioids and aggressive management of clonidine and other treatments potentially for xylazine withdrawal, and did not end up displaying any kind of withdrawal syndrome. The second group, this was 19 of the 73 patients, 26.4%, had what we thought could have been a distinct withdrawal syndrome. It was really hard to be sure. And there were a few different phenotypes here. You can go to the next part. Thanks, Jean Marie. So within the group with the possible withdrawal syndrome, we saw mixed agitated delirium toxidrome, where this toxidrome was often attributed to other substances. These were patients who often had recently used stimulants or had used synthetic cannabinoids. Patients were sometimes in the ICU. There was a lot of agitation. Hard to say whether xylazine withdrawal was playing a role in that, but it was not clearly due to xylazine. And then the other two cases, one was patients who had precipitated withdrawal, either from naloxone or buprenorphine. And then the last was insufficiently treated opioid withdrawal. We saw some patients who were only given low doses of methadone or low doses of oxycodone and had ongoing opioid withdrawal. Hard to say whether the xylazine withdrawal could have been playing a role in the withdrawal picture there. The last group is the group of patients who did have what we thought were otherwise unexplained symptoms. And again, we were looking for anxiety, restlessness, hypertension, tachycardia, and tremor, diaphoresis. Really only two patients that we saw in this group. And these two patients had unexplained hypertension, 180s or 100s, and or tachycardia maxed out around 90s. So not, in summary here, when we actually looked a little bit carefully to see what can we delineate, what is actually from xylazine, not a lot of clear evidence of a distinct withdrawal syndrome from this chart review.
Maybe we'll pause for a second there before we go into laboratory testing. I think there's a big impact on this sense. I feel like the Philadelphia community has a really potent communication pathway at the level of the street. I mean, I don't know, Rachel McFadden, if you want to comment on how patients' concerns about withdrawal influence their reticence to come to the hospital for treatment of their wounds, and how these things are kind of interrelated.
Sure. Yeah. Hi, everyone. I'm Rachel McFadden. I'm a nurse in HUP's emergency department, and I also work at Prevention Point, Philadelphia, at a low barrier harm reduction wound care clinic there. And first, I have one question for Ashish. Did you happen to find any difference in daily use between these three groups?
That's a great question. That's something I think we should look at. We haven't in detail yet, but I think that's something we can look into.
Yeah, I mean, I don't know what you could really conclusions you could draw from that, because from my understanding, the kind of like ratio of fentanyl to xylazine is so variable in the supply right now. But Jean Marie, to your question, I mean, you know, our clinic, we see folks 3 days a week. We exist explicitly because people, you know, the majority of our participants inject drugs and don't like going to hospitals because of withdrawal and because of pain, or kind of inadequate attention and treatment of those things. So it's the top of everybody's mind when it comes to having anything that needs an evaluation at a hospital. We do have, you know, seen some pretty great improvements in the last couple years, relatively speaking, at some of the major health institutions in Philly that are protocolizing withdrawal management the way that Ashish has kind of led and others have led at Penn. We have a great warm handoff system to Temple. They really use heroic doses of opioids to help folks through withdrawal, but you know, it's a big concern. And I'd like to call out Kelly Murray Grant, who I believe is on the call, who is a peer worker, certified recovery specialist at Penn. In 2020, Kelly was coming to meetings and saying there's this stuff called xylazine that everyone is freaking out about, and their anxiety is through the roof when they're in the hospital, and we need to be paying attention to this. And truly, Kelly was the first person I remember at Penn talking about xylazine and talking about withdrawal and talking about this anxiety.
And Rachel, I think that's so important. Thank you for mentioning that. I want to just also add something to this. Like, the takeaway from me from this slide is that there are two. One is what I mentioned about there not being clear evidence of distinct withdrawal syndrome that we could find tied to xylazine. But the other side of that is that these are really uncomfortable patients still. And there are other reasons that we found in addition to xylazine for that discomfort. And so this is in no way to minimize that experience of anxiety that patients might be feeling and that we might have not detected here. But I think one of the interesting things for me and surprising things for me from doing this chart review is how complicated this course was and how many other co-occurring issues could have been contributing to this course in addition to the xylazine.
Yeah, thanks, both of you. I did have one question sort of from Tony's slide about patients not seeking xylazine. And that's something that I heard in the beginning that was very difficult to avoid. But I've heard kind of an evolving conversation about people now seeking it out to avoid xylazine withdrawal specifically, so that they actually want the xylazine because they think that they need that to self-treat impending xylazine withdrawal. Given the overlap with fentanyl, it's probably pretty confusing. But Rachel, do you hear people? Have you reflected that shift in patients where they were trying to avoid it and now less so, or have they just given up in the futility of its kind of presence in so many of the drug samples?
Yeah, I had actually noted that as a question for Tony too. I think the latter. I think initially people, were noticing changes in their sedation and wounds that were undesirable. And so we're trying to switch, stamps to avoid whatever was causing this. Tranq was suspected. But now people, I think they seek it because they are concerned about the withdrawal. That's very anecdotal.
Sure. Yeah. And I think I've heard the same thing, and somewhat from patients, but maybe somewhat just from people who are, working with patients and that anxiety. It's a lot of interesting theories. Okay, well, let's move on. I mean, maybe we should spend like 1 minute talking about what has worked. Just because I know, I was part of the chart review, and then we put together our protocols. It would be probably appropriate to say that it's possible that some of the absence of withdrawal is because we did start to treat patients with more standing doses of clonidine and gabapentin, as well as full agonist opioids. So I think some of the non-findings are probably or possibly related to more aggressive treatment of withdrawal and those ancillary symptoms, even when treating opioid withdrawal, people can have even if they're getting buprenorphine or full agonist opioids. So we'll talk about where to find our pathway, but I don't know if Chris Martin or anyone from Jefferson or the other health systems want to talk about how they are managing these tricks up their sleeve in terms of prophylaxis against withdrawal. Chris is in 2 meetings, so we'll see if he's can unmute.
Yeah, no, I can pitch in a little bit, like, and I think, I don't think we have it published outside of the system right now, but we did roll out new guidelines that are published on the Jefferson Internet. Kind of based on the background of like pre-use of aggressive doses of full agonists and methadone in the hospital, falling back on the old standby clonidine. We've been using doses of that are essentially titrated to goal blood pressure while using agonists as well. I think the highest we've seen has been, I think there might have been one patient who got up to 2.1 milligrams of clonidine in a day and tolerated that well. But it literally was just titrated to blood pressure and heart rate with some subjective improvement too. That was beyond the guidelines that we published. I think we capped the recommendations at 1.5 a day. We have been using more, like in patients who are normotensive, using more tizanidine, 6 TID, 8 TID, and like more heroic cases. We've had 1 or 2 cases of symptomatic hypotension, mixing that along with other alpha agonists as well. I know you guys don't have guanfacine on your formulary, or at least I had heard maybe some of your hospitals don't. We've been using that for some patients as well. Had one patient who was actually sent to us on, had gone to an outside drug rehab because her PO had sent her there, was using over a bundle a day. Went into extremis at the detox that she'd gone to, was sent to an outside hospital, actually put on an Impella and had pretty significant vasoplegia. And she actually tolerated, I think we had gone to 4 or 5 milligrams of guanfacine per day, and they were able to decommission the Impella and get that out within like 2 days of starting that, which was interesting and impressive. But otherwise, I don't think we're doing much different than the other hospitals. We're using aggressive methadone. We have the connection with NARC that makes placement a lot easier for those patients, and the level 4 has helped a lot. Yeah.
Great. Yeah, thank you. So multimodal overdose, multimodal withdrawal treatment, including the gabapentinoids and the clonidine-like drugs.
Yes.
Yeah, great. Thank you. So Ashish, you want to talk to us a little bit about laboratory testing, and then we'll move on to wounds.
Yeah, absolutely. So we really don't know very much about the pharmacology or the pharmacokinetics of xylazine in humans. I don't believe there's almost anything published. So one of the questions we wanted to answer, or at least try to get a first approximation for, is how long does xylazine last in the urine? We know from other large animal models that exposure to xylazine for hours to, if you're exposed to xylazine for hours, if you're a horse or a dog, it really only lasts a few hours in the urine. But in this case, these are individuals who are often exposed to it chronically. And it was an open question whether, like fentanyl, something that's typically considered short-acting in urine, whether it actually lasts longer in urine. So we, right here, are displaying all of our urine xylazine tests. So on the x-axis here, you have time from ED presentation to when the actual urine specimen was collected. We organize this by the positive tests on the top and the negative tests on the bottom. What this helps us see is that the longest time period from ED presentation to a positive test was 43 hours. Any test sent after that 43-hour mark was negative. If you can, Jean Marie, progress to the next few clicks, thanks. So if you then compare that group on the top, the positive test to the negative test, just in the first 48 hours, time was not associated with positivity. Between those two findings, it looks like a first approximation for how long xylazine lasts in urines is probably on the order of 24 to 48 hours at most. Why is this helpful? I think if we're starting to develop more of these urine tests in different clinical settings, it's going to be important to know whether a test sent in day 3, 5, or 7 is actually useful. I know right now we don't have a lot of evidence-based guidance for what to do if a patient is found to have exposure to xylazine, but if it might end up affecting the workup for other etiologies of wounds, delirium, or withdrawal syndromes, it's going to be most helpful to send that xylazine test in that first 24-hour period. There are definitely limitations with this, right? This is by no means going to be definitive, but hopefully it's a first approximation. So one of the main limitations is a lot of patients use in the hospital. They come in expecting to have withdrawal, and that is a self-protective adaptation that makes a lot of sense for many of them. I don't know how many of these patients were using in the hospital. In our chart review, it looked like there were a decent amount who were continuing to use. So the true time that xylazine lasts might be considerably shorter than 24 to 48 hours. I think it's unlikely to be longer than that, though.
Yeah, great. And I don't know if you want to comment on, I think Miles had another explanation for why we might be detecting it out longer, which I thought was pretty interesting.
Yeah, I think Miles is one of the, I believe he's a fellow, I believe, in the laboratory medicine and pathology department. And his thought was that injection of xylazine might lead to it lasting a little bit longer, especially if patients are injecting these into wounds and ends up having kind of more of a subcutaneous effect rather than it being directly into veins.
Yeah, I thought that kind of made sense to explain some of these longer windows, but we'll have to see.
Yeah, Chris, and you mentioned that maybe they're using in the hospital. That's exactly right. I think they are probably using the hospital.
Sorry.
And so, yeah, I think 24 to 48 is probably the highest point. And rather than it being accurate that most of the people are lasting 24 to 48, I think that's the upper limit is what I think we can say from these data.
I have stories that involve bags of Funyuns that were not Funyuns, but rather fentanyl and xylazine. So
Fun in a different way, yeah. All right, so then the last piece of this is we then looked at just the tests that were sent in the first 48 hours, because I don't necessarily trust negative tests sent beyond that period. If you look just in the 48-hour period, what are some of the associations we're seeing here? This is really to be hypothesis generating. What we found is that xylazine positive associated with younger age, white race, fentanyl detection, methadone detection, and less frequent ICU admission. So the younger age and white race fits with my experience in Philadelphia here with the racial and age breakdown of patients who are exposed to opioids in different areas of the city. So it's not entirely surprising to me. The association with fentanyl is, as every other report has found. The methadone detection, I think, is probably more a result of the fentanyl detection. Patients who have higher fentanyl exposure are more likely, I think, to get methadone in the hospital in that initial one-day period. So I'm guessing that's more likely iatrogenic methadone. Most of the patients from the chart review we did were not in treatment. The less frequent ICU admissions is, I think, interesting, and it's in keeping with, I know, the finding from Jennifer Love's et al.'s paper that we're going to get to next. This might be another sign that the patients who are exposed to xylazine might actually be exposed to a smaller amount of opioid agonism, just as the amount of xylazine in the drug supply changes the amount of fentanyl. I'm kind of stealing this from Jennifer Love et al.'s discussion section, so I'll let her comment on that too. And then the last bit I'll just say is, I think if we click once again, Jean Marie, the length of stay was approaching significance there and was a little bit shorter actually for xylazine positive. So all of these were actually surprising. I think going into this paper, I would have assumed that xylazine positivity would have been associated with more frequent ICU admissions, longer length of stay.
Great.
Ashish, I can just comment very briefly about, we are looking at predictors as well from our data set and finding sort of similar things. The two that have stood out to me, and I have a little bit more work to do, is actually female gender is sort of a lower odds in what we're seeing. And then the other one that was approaching near significance was actually a self-reported history of anxiety. So we have a little bit more work to do there, but some overlap in what we're seeing with our national data.
Great, Jen, thanks. And we're going to get to you after the wounds, so we're going to move along. Do you want to just comment real quickly? This is for our health system, I think. Ashish and
Yeah. So this is exciting. So we have this xylazine test, but thanks to some work led by Jean Marie and others, there is this draft to add these mandatory questions to anyone sending a xylazine test. And our hope is that these questions will help us better understand the context for the drug use for these patients. So right now, the questions as they are last time opioids were used in hours, the amount of opioids / pills per day, the method of use, and whether there are any open wounds associated with their substance use. I'd love to hear if there's any feedback from this also from this group. I know there are lots of experts here on this call.
other things we could put into this order because it hasn't been deployed. And how do you feel as a clinician filling out a couple things to help us, with getting a little bit more data on these patients? It's really stuff that's generally not easy to find in chart review. All right, we can save this.
Yeah, if someone cannot fill that information out, because I'm seeing that it's required, like if they don't know the last hour from use, I'm afraid that they just won't be able to order it.
Mm-hmm. And that's definitely one concern. I think the other concern is that they'll just fill it out anyway, 1 hour or 5 hours, some best estimate, which would be, less helpful. We'll have to talk about whether or not we want to make this, optional data collection or just collect it standard for a period of time and see how it goes.
And I just want to raise up something that Sam Ho mentioned in the chat, which is, we've discussed potentially adding this to all UDS, which I think is another kind of the other side of the spectrum, to adding it to all of them, which would add a different kind of information. It wouldn't be as detailed for the patients we got it from, but it would be a little bit clearer to actually tell prevalence then of exposure. So right now it's biased by who's getting the test.
Great.
All right, I'll just finish off. This just summarizes some of these results from reviewing these charts here. It looks like the time for renal clearance is likely less than 24 to 48. It might be a lot lower than that if a lot of these patients were using, as people have been commenting. Xylazine positivity associated with fentanyl use, younger age, white race, and less frequent ICU admissions. Lots of variability in patient-reported symptoms as documented in the chart, but we did see examples of anxiety and restlessness, as have been noted elsewhere, and we did not find many objective manifestations of distinct xylazine withdrawal syndrome. Yeah, lots more work to do, but I think this hopefully adds a little bit more granularity to some of these discussions.
Great. Thank you, Ashish. Just to look on our website, Penn Center for Addiction Medicine and Policy.org, we have all of the clinical pathways for buprenorphine and full opioid agonists under clinical. We now have this new xylazine best practice there, as well as it's also posted under the harm reduction tab under all about xylazine. So we have some frequently asked questions and then the link to the best practices. We found that really helpful in the health system to point people to something that they can, quickly identify with a strategy. So with that, I'd like to turn it over to Rachel. Talk to us about the wound experience that she has both as a nurse in our EDs and the amazing work that she does at Prevention Point.
Thanks, Jean Marie. So no surprises here, I think, but just want to show kind of on two levels, the level of or the increase in tranq wounds that we've been seeing. So at Prevention Point Wound Care Clinic on the left side, and that's sort of the hat I'm wearing for this panel. Last year, we clocked 5 times the number of visits that we did in 2019. And this is reflected in city data too on ED visits for skin and soft tissue infections among folks with substance use disorder. You can see a bit of a bump in the rate in 2020, and then 2021, we really start to see the climb. I'm fairly confident we would have seen more people sooner in the EDs if there wasn't such a fear of withdrawal in hospital settings. The next slide includes some photos. Usually like to give a heads up. So there they are. At the clinic, we're seeing, kind of 2-ish types of wounds that we associate with xylazine. And I can talk more about kind of why we associate these with xylazine. But the first form generally starts at the site of an injection or injections. It emerges as this like irregularly bordered dark purple blister that then transforms, kind of grows and transforms into this dry adherent eschar. These wounds start deep and get deeper. These are the ones that after debridement will reveal bone and tendon, these deeper structures. And they mostly are on extremities, although sometimes we are seeing them on the chest, although those are not at the sites of injection. And then the second form we see in folks who do not inject at all, or they're smoking or snorting fentanyl that contains xylazine, or if they do inject, these wounds are developing away from injection sites. And they look a bit like what we associate with skin popping ulcerations, these kind of scattered coin-size ulcerations with a sort of friable, mixed non-viable tissue wound bed. Neither really start as an infection, and that's kind of one of the differences that we've noticed and set these apart from what we saw pre-tranq. But superimposed infections are really common, especially in folks who are unhoused or have kind of like a heavy burden of this devitalized tissue. Can go to the next slide. Thank you. Again, our clinic exists because people who inject drugs don't really go to the hospital very often. And a big reason for that, as mentioned earlier, is pain. So we pay particular attention to pain, both of the wound and potential pain caused by care. And sorry, the font's a little bit small, but tried to illustrate here on the left in this numbered list how we weave this consideration into the development of an individualized wound care plan that might deviate from the ideal, but perhaps works better for the person in front of us. So for example, a lot of the cleaners like Dakins and acetic acid that are easy to reach for in the hospital may not be tolerated. And we used a lot of more neutral alternatives. Additionally, our dressings are really built to debride devitalized tissue using topicals, but also be very non-adherent. So we love Adaptic. It really reduces the sticky factor and makes dressing changes much less painful, and dressing changes that are tolerable will happen. So that's maybe more for simpler wounds. For more advanced wounds, like the one on the previous slide, in our experience, in our opinion, surgical debridement is a great option. So you get maximal debridement with minimal pain in the OR. It can really beautifully reset the natural healing cascade within the wound. And it is a lot easier for community settings to work with a debrided wound. We do see missed opportunities for this in the hospital. However, folks who have these wounds know they need this debridement. And we've unfortunately seen people sharps debride themselves with kind of like self anesthesia. And I hope we can all agree that this should never happen. So I think there's a big opportunity for harm reduction here in ensuring that we're offering debridement whenever possible to folks while they're in-house. We also really try to be very real about what folks can do for follow-up. So for instance, we make sure that people know about all the low barrier harm reduction wound care options out there, since a referral to a specialty clinic that has strict scheduling and sobriety policies really just doesn't work for someone who has active and complicated substance use disorder. And I can share this wonderful resource on the right side that kind of lists all the harm reduction wound care options happening every day in Kensington. And hopefully those kind of options are going to be expanding throughout the city. We see harm reduction as kind of co-creating a workable plan that is informed by reality, which may include continued use. But this kind of planning is totally possible. We do it in the clinic all the time. So this is some simple suggestions from kind of like a harm reduction perspective on a wound care checklist for the hospital and for discharges. And this is, of course, in addition to clinical bread and butter things like testing for HIV and consulting the right people. Some of this is about pain, some of this is about stigma, and some of it is just getting to know what people are experiencing with these wounds. I think there's so much really dehumanizing media attention on tranq wounds right now. And we are not immune to that milieu, and neither are patients. So staying grounded in and really validating the human experience of what's going on is really important. And kind of hopefully will set a tone for, as xylazine becomes more prevalent in other locations, kind of inflect some good practice into care that we can spread also. I think maybe I'll finish up there. This piece of xylazine is really, these wounds are really changing the morbidity that we associate with injection drug use, but there's also a lot to say about changes in people's risk profile and risk for overdose. And I think I'll hand over to Jen here to talk about that.
Thank you, Rachel.
Thanks, Rachel. So hi, everybody. I'm Jennifer. I am a Penn alumni. I did my medical school and residency training in emergency medicine at Penn. I moved across the country for a brief medical toxicology fellowship to Oregon. And I am now back in New York, actually at Mount Sinai in Manhattan, finishing my 2-year research fellowship, and I'll be staying on as faculty there. And I work with sort of a national research group called Toxic, that is out of the American College of Medical Toxicology. And we recently published this paper here where we looked at xylazine in a multi-center study group. So this is now, at the time of the study, it was 9. Now it is 10 emergency departments across the country, out of Western Pennsylvania, New York, New Jersey, Michigan, California, Oregon, and we've now added Atlanta and Denver. And what we did is in this group, we collect waste serum. So patients with non-fatal opioid overdoses who come into any of these emergency departments are screened for possible opioid overdose, and we collect their waste serum. So no blood is taken as part of this study, but any blood that's used for clinical use gets sent to a central lab where we do mass spectroscopy testing against a library of 900 substances and look for all of the analytes that are detected in this patient population. And so what we elected to do was look at those who tested positive for xylazine versus those who did not test positive for xylazine, and look at some of the characteristics and clinical outcomes related to this patient group. And so what we found is sort of some of the trends that we've been talking about thus far. The biggest one is that this is largely concentrated in the Northeast and had the highest prevalence of xylazine positive detected patients in our Northeast geographic region, although we are seeing some also in the sort of central regions of the country and a lot less out on the West Coast. The second part is that pretty much everybody or near everybody received naloxone, and the total naloxone dose, while it did differ between the two groups and was slightly higher in the xylazine positive patient group, when we did the statistical analysis, the difference in dose was actually not statistically significant, but pretty much everybody got at least 1 dose of naloxone, and some people got repeat doses. And then the other thing, I think one of the most important things that we're trying to push out about the study is that xylazine was always detected with an illicit opioid. It was always detected with fentanyl. We did have one patient in the subset who detected xylazine with methadone, but nobody in the patient cohort had xylazine detected alone. It always tracked with an opioid. And so, Jean-Marie, if you go to the next slide, what we did find is that, like I said, while the difference in naloxone dose between the two groups is not statistically significant, we do need to be administering naloxone to these patients because it always follows with an opioid. Other things that we looked at severity of outcomes and the patients who received CPR or had as a marker of cardiac arrest. And we actually found that in xylazine positive patients, they had lower rates and a lower adjusted odds ratio of cardiac arrest. We also found pretty low mortality rates in our patient groups. So only one patient in the xylazine positive group ended up dying, 5 in the xylazine absent group. And most patients actually were discharged from the ER. So we have a pretty low admission rate for both ICU admissions and then total overall admissions, both inpatient admissions and OBS, like ED OBS admissions. We're seeing that largely in both groups that most patients get discharged from the hospital. So I think some of the messaging that we are really trying to push from this study is that, you know, because xylazine always tracks with an opioid, we have an easy treatment for this, and we need to be administering and pushing the message to administer naloxone to these patients. People should not be fearful of xylazine, that just because there is xylazine being used that it won't quote unquote respond to naloxone. The opioid will respond to naloxone, and that's what's going to save patients' lives. And so we've been trying to be very transparent and pushing that message a lot because it's not necessarily the message that the media is pushing right now.
Oops. Yeah. Thank you, Jen. And that's really the first study that we have, you know, to say that, you know, if somebody's using something that's 50-50 xylazine-fentanyl, that's probably better than 75% fentanyl and 25% xylazine. That the more that there's actually xylazine, there's less of a respiratory depressant effect. Of course, the wounds and all the other complications are terrible. So it's not exactly harm reduction, but I think it favors the idea that in overdose, perhaps it's not as bad as straight fentanyl. So I think we've answered a few of these questions, but I'd really like to hear from everybody. And Rachel, it was so powerful to hear of your work outside of the hospital and the need for the outside of the hospital resource. But a lot of the patients do end up in our hospital, maybe for other reasons, and have incidental wound care that needs to occur, or, you know, complications. So I know we have a big health system. I was recently, you know, part of the service at Presby. So I don't know, Doug, if you want to tell us what the options are there, and or others can chime in about what's available at HUP. And do you need to see all of these wounds, and like, how can we work together?
Yeah, great question. Yeah, I think Rachel's presentation was excellent. I agree with everything that she presented on in terms of the wound care that you're able to provide to these folks to, get them the right setup for wound healing, but also make it practical and make it the least amount of pain for the patient, and trying to optimize, that enzymatic and automatic debridement as much as possible. We see these patients at the Penn Wound Center. So for those of you who don't know, the Penn Wound Care Center is located at 3737 Market Street, which is Penn Medicine University City. We're on the 11th floor there. It's a multidisciplinary clinic. So I'm the dermatologist there, but we have podiatry and we have hyperbaric oxygen, and we have hyperbaric oxygen doctors who also see wound patients and plastic surgery and vascular surgery. So we've seen these patients. I'm actually seeing a couple of Judy Shertock's patients right now from Family Medicine, who she's treating for opioid abuse, substance abuse. And I think the biggest challenge we have with some of these patients is them coming to their appointments. So obviously doing wound care, like Rachel and a lot of folks are doing out in the community, that's absolutely key, treating people sort of where they're at. in a place that they feel safe going to, that's not stigmatized, where, close to where they're maybe using, or that kind of thing is key. Getting them to come to the wound center. I think there are multiple challenges for this. There are multiple challenges even for our patients who don't have addiction issues, who are socioeconomically disadvantaged, getting to the wound center all the time, for patients who have to make a copay all the time, getting their bandages. So we order these bandages from wound supply companies, getting those bandages delivered. It's hard to get bandages delivered to you when you're homeless, and you don't have a place to have them delivered to. And then, unfortunately, a lot of the things that we do in the wound center can cause pain for people, trying to do some sharp debridement. So I'm not a surgeon. So a lot of the debridement that I try to do, gentle debridement as much as possible in the wound center, is I use a lot of local lidocaine with epinephrine, injecting into wounds to get some of that blackened eschar off. Like Rachel was talking about, to set the wound up for healing, to get that granulation tissue in. So a lot of the things that we do can cause pain. So trying to manage that in this patient population is really tricky. So I think it's great when you're a wound care provider like me, if you have somebody like Judy Shertock in family medicine who has a relationship with this patient, and you're working closely with them to manage that, and sort of talking to the patient about that. That's a key piece, because I feel like some of these patients they might come once and we do something to them and they basically are like, I'm not going back there because it's just too much pain and misery for me. So I think that's the biggest challenge. We're happy to see these patients, but I think a lot of the challenges become, these are patients that we would really want to see maybe every couple of weeks, maybe every 2 or 3 weeks even. And seeing them back. And again, I think the wound bandage piece is tough because of all the things that have to be done to get those bandages covered through insurance, whether you're talking about Medicaid, Medicare, there's lots of forms to fill out. Those all have to be sent out through a medical supply company. And again, they have to be delivered somewhere. So having these other options for wound supplies, I think, is really important, because that's a key piece of the wound healing. Is patients having access to these bandages to set them up for healing.
Thank you, Doug. I know we do a lot of substance use navigation in our center, getting people to various other treatments with, tokens and phone calls and other kind of reminders. So we have thought a lot about how to integrate wound care assessments and wound navigation to some sort of virtual substance use navigator program, which we have already, but we just don't include wound care. And so we've written some grants to suggest that we could do that. We sort of need to pilot it. And one of the things that we've talked about is, piloting a wound assessment via telehealth, because what I see as an emergency physician is a lot of patients get admitted to the hospital without really a wound endpoint, because the wounds maybe, look terrible, but look the same yesterday and look the same that they did, when they were last seen at prevention point, so I have a lot of thoughts about ways of kind of creating like a wound registry so that we know what the wound plan is for a large cohort of people in the city, and then being able to continue to, help people go from place to place to what the next step might have been. We have Care Everywhere and a lot of other ways for the health system to communicate, but we don't have it, it's sometimes buried deep in a lot of other EHR stuff. Go ahead, Jen.
For Rachel and for Doug, do you think there is importance in understanding what the pathophysiology of these wounds is? Or do you think that sort of what we do now as the standard of wound care is just what should be sort of disseminated and practiced? Because one thing I think about as an ER doc is that like ER doc reflexes like wound, infected, antibiotics, and like bringing these people into OBS for 24 hours for empiric antibiotics can cause a whole lot of problems. I worry about antibiotic stewardship and like, are we then breeding resistance to antibiotics in the community? But perhaps perhaps we don't really need to understand the pathophysiology because of your knowledge base and what you're seeing right now?
Yeah, great question. So I think, the way I think of these wounds is, it's a ischemic process. So xylazine is a vasoconstrictor. So, when you see that black eschar on there, that's usually a sign that there's some kind of what we call vasculopathy in dermatology. So that means there's something going on with the blood vessels. There's either something in the blood vessels or there's an ischemic process. And so I really think of these wounds being ischemic. So there's a lack of blood flow there and the tissue dies, and that black eschar is there. And there's, as Rachel pointed out, there's a lot of tissue destruction under that black eschar. And in some ways, the eschar, I feel like it's adaptive in a lot of ways. It's like a wound bandage in and of itself. It's covering the wound, it's protecting it, but at the same time, it's probably only a matter of time before it's going to get infected, especially if a patient is living on the street, they don't have access to sort of the normal things we are doing every day, bathing and things like that. So there's going to be bacteria that are going to get in there and cause problems. So I think, doing things focusing on very simple things in terms of the wound care is a key piece, like that, using whether it's Santa ointment, which can be really expensive, an enzymatic debriding agent, just doing topical antibiotics like mupirocin or plain Vaseline, and then lots of adaptic, which is that oil emulsion gauze or Vaseline gauze, and then some kind of secondary dressing to catch that drainage if there is any there, and then some kind of roll gauze to keep it covered. I think if you're doing those simple things, you're doing a lot for that person to try to set them up for healing. The antibiotic issue is, if you go back to that picture, if you look at that picture that Rachel showed of that, all that large black eschar there, there's not really infection there. There's no surrounding cellulitis. That might be a patient who shows up and has a normal white blood cell count. They have no fever. You're right. Probably doesn't need antibiotics. The problem is eventually that wound will have bacteria that will overgrow on it. That wound will become what we call critically colonized, which will slow the healing. And these bacteria live in biofilms. They don't necessarily respond to IV antibiotics. They really need to be debrided. And then that patient needs to be closely monitored for infection. And I think that's why it can be hard to create sort of a one size fits all approach to these patients when they come into the emergency room or they come into the clinic, because they each need to be evaluated individually. And again, I think this is where places like the wound center can be helpful. And there was a question in the chat earlier about, case management, trying to help coordinate appointments at the wound center. I'm all for it. I'm all for trying to make that all happen. I think where the problem becomes is when patients really start to no-show a lot. And that's going to affect, the wound center and the wound center's productivity. And there's obviously a lot of pressure in the health system to keep productivity up. And of course, we want to be thinking about what's right for patients, definitely. But that does become an issue if patients are having trouble getting to their appointments. And the wound center is unique because it's not owned by any department at Penn. It's owned by the Presby. It's run by the Presby Hospital. And so it's a little bit of a unique thing. It's not owned and operated by a department at Penn. So that sometimes makes some of the politics a little unique for the wound center. So, but these things can be done. We can certainly work towards making it work for these patients who definitely need our help.
Yeah, that's great. I knew very little about the wound center, and I have to thank some of my colleagues who connected us, but I know it's 5 o'clock and I'm happy to stay on for a few more minutes to chat, but I think the kind of the closing statements would be to connect some of us in the Penn Health system with, all the things that we need to kind of optimize care, navigation, and, when we can call on your expertise, for patients in the hospital. and it's just become a very common occurrence, including, the patients in the emergency department that, maybe we inadvertently reach for a higher level of care and sometimes not so necessary. Rachel, Ashish, Jen, and Tony, and Doug, thank you all for coming. I think this is just the tip of the iceberg, but I know we have a lot of follow-up conversations and a lot of interest nationally in figuring out, from our Philadelphia experience, how we can mitigate this as it inevitably spreads across the country, just like fentanyl did 5 years ago. We're really in a unique situation, and we have the resources at Penn and in Philadelphia to do this. And along with the declaration of this as an emerging threat, there will be, funds for, I think, research and enhanced care that we're certainly in a position to go after. So with that, I'll encourage anyone who needs to hop off, and then we can just chat if anyone, wants to continue.
I will say there's a question in the chat about this issue of people getting wounds where they're not injecting. I have a couple thoughts on that. When you read about this, people say, oh, well, there's vasoconstriction, and maybe when you're using xylazine, there's, hypotension and bradycardia, and maybe there's, other peripheral vasoconstrictive effects beyond, locally where you're injecting. That might be the case. I think what also might be happening sometimes is, if you're injecting drugs and you're getting staph into the area where you're injecting, you can have situations where you have what we call ecthyma, where the staph bacteria are getting into the bloodstream where you're injecting, because you might be injecting into a wound that's already developed where you're injecting xylazine. The blood vessels are constricting, you have low blood flow, the area becomes necrotic and dies. That's where you're getting that black eschar on there. And then if you have bacteria that are getting into the bloodstream and seeding in other areas of the skin, we call that ecthyma. And it happens with staph. It certainly happens with gram-negative organisms that we see. So I wonder if sometimes, and we see these patients in the hospital, we get called for this, for patients who are using these substances. And sometimes I wonder a couple things. I guess sometimes I wonder whether sometimes that's ecthyma. If the patient's admitted, we know they're septic, their blood cultures were positive. Is that some of that? It could be. Maybe there are some other effects of when you inject and there's other vasoconstriction in other areas. I guess that's possible. And then other times, I'm not sure, when we ask patients about where they're injecting, I feel like most of the time they're pretty honest about where they're injecting. When they ask, they'll tell you, oh, I inject here. Did you inject in these other areas? No, I've never injected there. So I don't think they have any reason to lie. They're usually, I find, to be very truthful about what's happening. So, but sometimes I do wonder whether they are injecting in other areas. But I guess, I think most of the time they are really telling the truth, that they're developing wounds where they're not injecting. So those are my thoughts, but I often ask myself too, I scratch my head sometimes when I see these patients and wonder what's happening with some of that. So it's a good question.
I just want to add one thing. I spoke to Misha Rosenbach about biopsying these lesions and what the value would be. And he taught me that there isn't much value in biopsying a chronic wound, but that maybe we could learn something from some of these earlier emerging wounds about pathophysiology or dermatopathology. Should we try to get connected with somebody if somebody has, some of those wounds that Rachel was showing that were a little earlier? And I've seen coin-shaped lesions where the skin is completely intact. There are a few coin-shaped lesions, but there isn't really any ulceration yet. And what the patients will say is it starts that way and then it ulcerates into like a pit. So could you biopsy one of these things where the skin is still intact and there's some active process? And I just also want to echo that I think from all the patients I've seen, many have told me that they are not getting wounds where they're injecting. I mean, getting wounds in places where they don't inject, and/or people who snort who are having wounds. So I don't think, at least from our side, I think we're pretty confident that's happening.
Yeah, so definitely, the best thing to do, it would be to biopsy something that if they felt like it was some kind of nodule under the skin or was a fullness in the skin before it ulcerated, that would be ideal to biopsy. Because once it ulcerates and opens and then you biopsy it and you see bacteria there, it was like, well, which came first, the wound or the bacteria? certainly doing a biopsy on some kind of nodule that's popping up for both H&E to look at under the microscope and to do a tissue culture on it to see if anything grows there, that would be extremely useful. I think Misha's point is that, if you're biopsying a wound that's already open and kind of there, you might biopsy it. Most of the time when you biopsy that, you're going to be disappointed in what you find. It's going to be a non-specific kind of pathology report. But some kind of nodular process, that would be more interesting, because then you're wondering if, there's some other kind of inflammatory process that's happening there, whether it's some kind of paniculitis, like inflammation in the fat that's happening, or some other kind of maybe granulomatous inflammation that's happening in reaction to something else that's happening distally, or something that somebody's using or they're injecting with. I agree. That would be much more interesting to do.
Thank you. Kit, you want to unmute? At least you have your hand up.
Hey, thanks. Can you guys hear me? I'm on the road,
Yes.
so apologies
Yes.
for being off camera. Thanks, Doug, for joining, and Jean Marie, amazing panel, and to all our colleagues and panelists. Appreciate you being here. Yeah, it's I've talked to Mark Binkley, who's our colleague in the emergency department, also works in the wound clinic, and he highlighted the challenges. I think it's just not meeting people where they are, and in terms of location and sort of stability in their life, and all the other sort of social determinants there. And I really do think that we need some sort of low barrier kind of urgent care type place where people can come and get their, all their needs met, and it has to be sort of integrated with, sort of the addiction medicine work that Jean Marie's leading. So, people can come back and get their bupe dosing. They can have case management resources, and then they can get their wounds taken care of. And if it requires some sort of additional sedation or analgesic treatments that we emergency physicians commonly deliver, that's something that can be done. So I just wanted to plant the seed that I think there's a lot of opportunity for innovation. I like what Jean Marie said about some sort of registry or some digital option for tracking wounds across settings, or doing consults that could prevent unnecessary admissions. And so anyway, I just wanted to put that out there. Thanks.
Thank you, Kit. Yeah, Kit was the inspiration to get this together, just so that we kind of had a conversation across the health system and across the city. I know there have been several similar, but it just felt like we do have amazing resources in our health system, including people like Rachel and Doug, and we just need to kind of connect the dots, because we have, a few grants here and there that sometimes we struggle with how to spend them, and so tokens and other kinds of things can sometimes be not so difficult, and wound care and, and harm reduction kits. So we can follow up with all of everyone else. I don't know if there's any other questions in the chat, if anyone wants to unmute and speak up. Otherwise, I think we can wrap this up, and some super great take homes to really continue this work. And, Rachel, I just want to say you continue to amaze me in your advocacy in every single way. It's just been a wonderful partnership, and I'm so grateful to work side by side with you in the ER. You've made it a really different place over time, and that's hard to do as a one-man show. You're amazing.
Thanks. I mean, I think this panel and everyone, the panelists and all the work that camp has done is such a testament to your leadership, Jean Marie and Kit Delgado, and we have a pretty amazing team.
Totally an amazing team. And a quick thank you to the rest of our substance use navigators. We have a huge group that does so much work behind the scenes and takes so little credit for it on the front lines. I don't want to be the one to front all of this. And I know Maggie is also at the same meeting as Ashish, but she's also integral in a lot of the work that we do. So thanks, everybody. Hopefully this will be recorded and on our website. I believe that all will happen, and we can refer back to it. And Doug will be in touch with some ways that we can continue to work together. So thanks, everybody.
That's great.
Have a good day. Enjoy the beautiful